Assalamu alaikum. Bismillahir Rahmanir Rahim. Ar-Rahman allama al-Quran खलक़ल इंसान अल्लमहुल बयान। तो आज फिर आपसे बात हो रही है. So before start, remember to blaze a path of your own brilliance and illuminate the world. You all are brilliant in one way or the other. Keep following, keep working, and you will do better. So our today's topic of short case is lymphadenopathy. It is a very common case, and before doing that, you see that there is a Voltaire ring consisting of tonsils, adenoids, lingual tonsils. Then there are cervical lymph nodes. Then there are inferior clavicular lymph nodes, axillary lymph nodes. There are the hilar lymph nodes, epitrochlear lymph nodes, paraaortic lymph nodes, inguinal lymph nodes, popliteal lymph nodes, appendix, Peyer's patches, and spleen and mediastinal lymph node. So the command can be: this is 8-year-old boy or 2-year-old boy who has a swelling of neck and axilla or groin region. Do the general physical examination and relevant. So before every short case, you start with the introduction, consent, exposure, which should ideally be in shorts, but you have to take care of the modesty and weather. Then after that, hand sanitization. Before any long short case, you have to do the general look to see whether the child is sick or well looking, cyanosed or respiratory distress at rest. Is there any pallor or jaundice? Is there any diagnostic or dysmorphic features? And what is the nutritional status of the child? Then after that, you check anthropometry while standing, that is height, weight, and FOC. If the child is sitting, start from the fingers. Check the clubbing, koilonychia, leukonychia, then palms for palmar erythema, pallor. Remember to compare with your own palms. Then wrist for the pulse, respiratory rate, and touch for temperature, and at the same time put thermometer in axilla while counting heart rate and respiratory rate. Then check for the wrist widening, which is a sign of rickets. Then in the arm, blood pressure, you must offer it at the end, but don't forget it. Epitrochlear lymph nodes, BCG scar mark. Then in the axilla, you check the axillary lymph nodes. Head, you check the head injury or wound on the scalp. Then eyes for the pallor, jaundice, cataract. Ear for otitis media, mastocytitis if there is cervical lymphadenopathy. Then mouth, check throat for oral thrush, pharyngitis in case of Epstein-Barr virus, infectious mononucleosis. Cervical lymph nodes, measure the largest lymph nodes. Comment on size, consistency, tenderness, redness of overlying skin, mobility, attachment to the overlying skin or underlying structures, and any draining sinus. You remember these features should be checked for all the lymph nodes. And while the child is lying, you check the chest and auscultate for signs of tuberculosis, abdomen for hepatosplenomegaly, inguinal lymph nodes, skin for petechial bruises, bone tenderness, and checks leg edema, and see the back. And at the end say that I want to check the blood pressure and plot height, weight, and FOC on centile charts. I have made a hypothetical description. I've just examined 8-year-old Junaid, who is sick-looking, undernourished child without obvious respiratory distress and cyanosis at rest. He was conscious and cooperative during my examination with the cannula in his right hand. He was markedly pale with visible neck swelling. His pulse was 110 beats per minute, respiratory rate of 25 per minute, and temperature of 102 degree Fahrenheit. His height is 130 cm and weight is 27 kg. Cervical lymph nodes are palpable in anterior and posterior region. The largest measuring 5 into 5 cm, which is firm in consistency, discrete, non-tender with normal overlying skin. They are non-mobile, not attached to the overlying skin or underlying structures, without any draining sinus. No other lymph nodes in axillary and inguinal region are palpable or enlarged. Liver is palpable 5 cm below right costal margin, with a total span of 11 cm, smooth surface, round borders, non-tender, and is not pulsatile. The spleen is palpable 6 cm below left costal margin, with notch palpable, and there are multiple petechiae on the body. There is no clubbing, palmar erythema, BCG scar was present. No ear discharge, oral thrush, sore throat, and breath sounds are vesicular. There's no pedal edema and no bony tenderness. I want to check blood pressure, plot height and weight on centile charts, and see temperature record. So the differential diagnosis, you consider infections such as the tuberculosis, Epstein-Barr virus, cytomegalovirus, leishmaniasis, and in malignancy, leukemia, and lymphoma. Few things about infectious mononucleosis. It is called Epstein-Barr virus. 90% cases the lymph node enlargement, 50% cases spleen is enlarged, and 10% cases liver is enlarged. Lymph node involvement is anterior, posterior cervical, submandibular, and epitrochlear, particularly on the junction of both soft and hard palate. 3 to 15% patients have rash, 80% rash after the intake of ampicillin. This is very specific thing. The labs are 90% greater than 90% are lymphocytes, 20 to 40 and atypical lymphocytes large with folded eccentrically placed nuclei, low nucleus to cytoplasm ratio. Heterophile antibody test or Paul Bunnell heterophile antibodies often or IgM agglutinate sheep RBCs. Monospot test agglutinate horse RBCs. Titers greater than 1:28 to 1:40 are positive. Anti-EBV antibodies. There is no specific treatment. Acyclovir can be considered. Prednisolone 1 mg per kg for 1 week and then taper within 1 week. The complications are splenic rupture or hemorrhage, airway obstruction due to tonsillar and oropharyngeal lymph node swelling, GBS, hemolytic anemia, aplastic anemia, Rye syndrome, Alice in the Wonderland syndrome, metamorphosia, and mild thrombocytopenia, pancreatitis, and parotitis. A few things about the differentials as per the region wise. In the cervical lymph nodes, consider throat and scalp infections, tuberculosis, Kawasaki disease, autoimmune lymphoproliferative disorder, sinus histiocytosis, catch-sky disease, infectious mononucleosis. Anterior auricular cases, you consider eye infections, oculoglandular tularemia, facial cellulitis. Case of post-auricular, you consider ear infections, viral infections like rubella and parvovirus. In case of supraclavicular lymphadenopathy, on the right side, mediastinal infections or tumor, while on the left side, abdominal tumor, lymphoma, and tuberculosis. Epitrochleal lymph nodes are palpable in case of sarcoidosis, syphilis, lymphoma, and infectious mononucleosis. Inguinal lymph nodes are palpable in case of UTI, venereal infections, plaque, legs and perineal infection. In axillary lymph nodes are palpable in case of chest infection or tumor, acute lymphoblastic leukemia, lymphoma, cat scratch, and brucellosis. Higher lymph nodes are palpable in case of lymphoma, tuberculosis, fungal infection, sarcoidosis, acute lymphoblastic leukemia, cat scratch disease. Mesenteric lymph nodes are enlarged in case of mycobacterium infection, Yersinia, measles, group A streptococcus, and malignancy. So the differential diagnosis of generalized lymphadenopathy in common in infant, it's the common causes of generalized lymphadenopathy in infant is toxoplasmosis, CMV, and HIV, whereas the rare causes include the tuberculosis, leukemia, metabolic disorders. Whereas in child, the common causes are the viral infections like Epstein-Barr virus, CMV, and HIV, while uncommon causes are TB, leukemia, lymphoma, SLE, HLH, whereas in adolescents, the viral infections are common. Generalized lymphadenopathy is the involvement of more than two non-contagious group of lymph nodes. So it includes infections in which viral which are common such as EBV, CMV, URTI, measles, varicella, rubella. Bacterial infections such as brucellosis, TB, typhoid, septicemia. Fungal infections such as histoplasmosis and coccidiomycosis. Protozoal infections such as toxoplasmosis. Inflammatory or non-infectious causes include rheumatological disorders such as GIA, SLE, sarcoidosis, storage disorders such as Gaucher disease, Niemann-Pick disease, serum sickness, whereas the malignant causes include leukemia, lymphoma, and medulloblastoma, and drug reaction and hyperparathyroidism. Whereas the localized lymphadenopathy, in which there is involvement of single lymph nodes or multiple contagious lymph nodes. In case of cervical infections such as viral, upper respiratory tract infection, infectious mononucleosis, rubella are common. The bacterial infections include group A streptococcal pharyngitis, staphylococcal pharyngitis, cat's sky disease, tuberculosis, toxoplasmosis, Kawasaki disease. Malignant causes, as mentioned before, leukemia, lymphoma, neuroblastoma, submental or submaxillary, such as dental infection, lymphadenitis, occipital lymphadenopathy is because of local infection, tinea capitis, lice, roseola, preauricular in case of skin or eye infections, mediastinal like leukemia, lymphoma, sarcoidosis, cystic fibrosis, granulomatosis such as tuberculosis. Supraclavicular lymph nodes are involved in lymphoma, tuberculosis, histoplasmosis. Axillary lymphadenopathy occurs in case of infections such as cat disease, brucellosis, non-Hodgkin lymphoma, juvenile idiopathic arthritis. Abdominal lymph nodes are enlarged in case of acute mesenteric adenitis lymphoma. Inguinal lymph nodes are enlarged in case of local infection and diaper dermatitis. So thank you very much for your listening. This is basically a guideline about how to proceed in a patient in which you are ordered to do the GP and you find some swelling or lymph nodes. So I pray that may Allah be your helper, protector and guide. Looking forward for your feedback. May Allah bless us. Allah Hafiz.